discussed general virology with you, and I am going to begin with special virology today, and we'll discuss herpes simplex virus and varicella zoster virus. Both of these are from herpes viruses family. You should know classification of herpes viruses, especially the biological classification, different types of herpes viruses, modes of transmission, pathogenesis, clinical features, and laboratory diagnosis of herpes simplex virus and varicella zoster virus. Herpes virus is a DNA enveloped virus. Members of herpes viruses family, herpes simplex virus type 1 and 2, these are the alternative names. Varicella zoster virus, and today we are going to cover these two viruses, Epstein-Barr virus and cytomegalovirus. Human herpes virus 8 is known to produce Kaposi sarcoma in AIDS patients. Biological classification. You can see that there are three subfamilies. The first one is alpha family. And the herpes simplex virus type 1 and 2 and varicella zoster virus, they are going to infect epithelial cells. And they are going to hide themselves in neurons. I'll talk about what is latency. So they would become latent in neurons. The beta family, which includes human herpes virus 6, 7, and I would say the important member is cytomegalovirus. So it can become latent in T lymphocytes and glands. Gamma family. Human herpes virus 8, and most important one is Epstein-Barr virus. So it will become latent in lymphocytes, which are B lymphocytes this time. Few major differences between members of this family. The first one is presence of a vesicular rash. So this is a vesicular rash. I'll talk about what's a vesicular rash later on. Herpes simplex virus, varicella zoster virus, both of these are going to produce a vesicular rash, whereas cytomegalovirus and Epstein-Barr virus do not produce a vesicular rash. It's a very important point. If we talk about multinucleated giant cells, so these are multinucleated giant cells. These are multinucleated giant cells, okay? So herpes simplex virus, varicella zoster virus, and cytomegalovirus, they're going to produce multinucleated giant cells. Let's try to understand pathogenesis of both herpes simplex virus and varicella zoster virus with the help of this picture. Once the virus has produced infection at the site of initial infection, so by retrograde axonal transport, it will move towards ganglia where it will become latent. It will hide itself. The virus would hide itself. Once the appropriate stimulus is there, for example, exposure to sunlight, trauma, immunosuppression, this would reactivate the virus, and with the help of anterograde axonal transport, it will move to the initial site of infection and it will start producing infection. For example, it starts to multiply in the epidermal cells. What is latency in infected neurons? Herpes simplex viruses and varicella zoster virus, they are noted for their ability to produce latent infections. In these infections, the acute disease is followed by an asymptomatic period during which the virus remains in a dormant state. When the patient is exposed to an inciting agent or immunosuppression occurs, reactivation of virus replication and disease can occur. In latently infected cells, such as herpes simplex virus infected neurons, circular herpes simplex virus DNA resides in the nucleus and is not integrated into cellular DNA. Similarly, transcription of herpes simplex virus DNA is limited to a few latency-associated transcripts. These non-coding regulatory RNAs suppress viral replication. Reactivation of viral replication can occur at a later time when the genes encoding latency-associated transcripts are excised. The virus can be reactivated from latent state by a variety of inducers such as sunlight, stress, hormonal changes, fever, trauma, and they can also be immunosuppression. In case of herpes simplex virus, immunity is incomplete and there can be reinfection, reactivation. The cell-mediated immunity is important in limiting herpes virus infection because its suppression can often result in reactivation, spread, and severe disease. In case of varicella zoster virus, varicella is going to have lifelong immunity and it would just occur once, but in case of zoster, there can be repeated episodes despite immunity to varicella. And the frequency of this zoster infection increases with advancing age. Typical lesions of herpes simplex virus. The first one is vesicle. It contains serous fluid which is filled with virus particles and cell debris. When the vesicle ruptures, virus is liberated and it can be transmitted to other individuals. And then is multinucleated giant cells which you can observe under microscope. These giant cells are produced with molding of nuclei as they are crowded together. Viruses can actually cause abnormal cell division in epidermal cells, and these are going to create multinucleated giant cells. These epidermal cells are much larger than normal epidermal cells, and then you can find out the peripheral margin of the chromatin and a ground glass appearance of the nuclei. So this is actually a cytopathic effect. If you remember, in general virology, we had discussed examples of cytopathic effect, which is given by some viruses. There is a long list of clinical findings of herpes simplex virus type 1. And then you can see that erythema multiforme is produced both by herpes simplex virus type 1 and type 2. We'll discuss the details of herpes simplex virus type 1 first. Herpes labialis, also known as fever blisters or cold sores. These are crop of vesicles at the mucocutaneous junction of lips or nose most of the time. These are painful vesicles clustered together and later on they can ulcerate. And there are recurrences. Gingivostomatitis primarily occurs in children characterized by fever, irritability, and vesicular lesions in the mouth. These lesions heal spontaneously in 2 to 3 weeks. Keratoconjunctivitis is characterized by corneal ulcers and lesions of the conjunctival epithelium. Recurrences can lead to scarring and blindness. Herpes simplex encephalitis. It is characterized by a necrotic lesion in one of the temporal lobe. There is fever, headache, vomiting, seizures, and altered mental status as typical features of encephalitis. The CSF findings are moderate increase in number of lymphocytes, moderate elevation in amount of protein, and a normal amount of glucose. However, the mortality rate is high in case of herpes simplex encephalitis. Hepatic whitlow is a pustular lesion of the skin of finger or hand, and it occurs in medical personnel as a result of contact with patient's lesions. Herpes gladiatorum, as the name indicates, it occurs in wrestlers and others who have close body contact. It is characterized by vesicular lesions on the head, neck, and trunk. Disseminated infections such as esophagitis and pneumonia, it can occur in immunocompromised patients with depressed T cell function. Herpes simplex virus type 2 clinical findings. Herpes genitalis, or you can say genital herpes, which is very important clinical finding. It produces painful vesicular lesions. Again, they're in the form of clusters, and you can find them in case of male and female genitalia or anal area. The lesions are more severe in primary cases than recurrences. Primary infections are associated with fever and inguinal lymphadenopathy. Asymptomatic infections can also occur both in men, for example, in the prostate or urethra, and in women in case of cervix, and this can be a source of infection of other individuals. Neonatal herpes can originate chiefly from contact with vesicular lesions within the birth canal. In some cases, there are no visible lesions. The virus is shed into birth canal, and that is by asymptomatic shedding, and this can infect the child during birth. Neonatal herpes can vary from severe disease, for example, disseminated lesions, to milder local lesions involving skin, eye, mouth, to asymptomatic infection. Aseptic meningitis is usually a mild, self-limited disease with few sequelae. Erythema multiforme, it is an immune-mediated reaction to the presence of herpes simplex virus antigens. You can see a central red area surrounded by a red-colored ring. The surrounding skin is normal. So this is target or bull's eye lesion, and this erythema multiforme can also be produced in case of other infections, and this is also known as Stevens-Johnson syndrome. Lab diagnosis of herpes simplex virus, and I will also talk about the varicella zoster virus simultaneously. Refresh your memory regarding the general viral lab diagnosis. So you will follow the same general scheme. First is direct detection, and this is with the help of microscopic examination. You can make a smear which is called as Zank smear. Cells are picked up from the base of vesicle and they are stained with either Gemser stain or toluidine blue, and you will find multinucleated giant cells. I've already shown you these multinucleated giant cells. Or you can use the electron microscope, and this is obviously for visualizing the virus particles. You can go for antigen detection, and this is with the help of direct immunofluorescent test. Then is nucleic acid test, PCR in case of neonatal herpes and encephalitis. It's a sensitive test for herpes simplex virus diagnosis. But in spinal fluid, virus is rarely recovered. Virus isolation, it's a definitive approach. So from tissue culture, you can observe cytopathic effect in about 1 to 3 days once the virus is grown in a cell culture. And then you can identify the virus from the cell culture either by fluorescent antibody staining of the infected cells, or you can perform ELISA test. Serological tests, they would be useful only in primary infection, because once the antibodies are there, they would not be of much significance, and the diagnosis of recurrent infections again would be of no use, because many adults already have these circulating antibodies, and recurrences rarely cause a rise in antibody titer, so it is of limited use. So you can perform neutralization tests. We have discussed all about these tests in detail in general virology: complement fixation test, enzyme-linked immunosorbent assay test, immunofluorescent test. And we would perform the same tests and will follow the same scheme in case of varicella zoster virus. But mostly the varicella zoster virus is diagnosed clinically, but at least you should know the Zank smear, viral culture, which are important tests. This is the Zank smear again, showing multinucleated giant cells. Let's quickly recap herpes simplex virus and varicella zoster virus. If it is herpes labialis. Then you will find crops of vesicles, usually at the mucocutaneous junction of the lips. They will turn into blisters and finally into painful ulcer-like lesions, and initially patient can have low-grade fever. Similarly, in case of genital herpes, low-grade fever, initially tingling sensations in the genital area, followed by appearance of blisters, which after a few days turned into painful ulcer-like lesions. So this makes diagnosis of genital herpes. In case of varicella zoster virus, shingles are more important, and there can be a history of painful rash restricted to only one side of the body, and the rash is vesicular in nature. Patient can be of old age, immunocompromised, and if the lab diagnosis mentions about multinucleated giant cells, then you have to think of all of the viruses which can produce multinucleated giant cells. And obviously, you're going to correlate with the clinical signs and symptoms and make your diagnosis. So if the rash is restricted to one side of the body, it is painful vesicular rash, and the patient is, let's say, immunocompromised, then the diagnosis would be shingles. Thank you.